Good morning. Welcome to the Gender Institute's Winter Symposium on Reproductive Justice. I'm Carrie Bramen, the director of the Institute, and it's wonderful to see so many of you here this morning. This event is a collaboration with the Erie County Commission on the Status of Women, and I'm grateful to its executive director, Carrie, for all of her help. I also want to thank Planned Parenthood and Sarah Vernon in particular for helping to organize today's event. Alyssa Benuski, head of the UB Undergraduate Society of Feminists, organized last night's screening of the documentary Jackson. We also received generous support from the Baldy Center, the UB Law School Dean Aviva Abramovsky, and the Samuel P. Capon Chair, Professor Jorge Gracia. And as always, I want to thank the amazing and generous staff of the UB Gender Institute, Becky Burke, and our graduate assistant, Anne-Marie Butler. Today's event was inspired by a national conference, the National Association of Commissions on Women, that Karen King hosted in Buffalo last July, at which Dr. Jamila Parrott gave a powerful talk on reproductive justice. Dr. Parrott spoke about the conceptual shift from reproductive rights to reproductive justice, where the former focuses primarily on pro-choice issues. The latter situates these issues within a broader context that involves economic and racial justice. Reproductive justice includes such issues as affordable housing, access to health care, food security, affordable childcare, living wages, safe neighborhoods and schools, and challenges to institutional racism. From the perspective of this human rights framework, one issue cannot be seen in isolation from others. After Dr. Parrott's talk, Isabel Marcus said to me, "Let's bring Jamila back to Buffalo." And after several months of collective brainstorming and discussion about the form and focus of today's event, Dr. Parrott, Karen King, Isabel Marcus, and myself decided to focus on two things in particular. First, what is the relation between theory and practice? How does the conceptual shift from reproductive rights to reproductive justice affect community action? And second, what are the connections between the national and the local? In other words, how can national conversations influence local practices and vice versa? The form of today's event reflects these questions. Dr. Parrott's keynote is paired with panels of local clinicians and activists who will discuss the important strides made in Buffalo with regard to reproductive justice and its ongoing challenges. Unfortunately, our second keynote, Professor Elena Gutierrez from the University of Illinois, Chicago, is unable to join us today. One of the risks of organizing a winter symposium is not only the weather, but also flu season. Although we will certainly miss Dr. Gutierrez's perspective in working with immigrant communities in Chicago, we have altered the schedule slightly to expand the time allotted to the local panel, which will now go until 1 p.m. 2018 is an important year to talk about reproductive justice. January 22nd, 2018 marked the 45th anniversary of Roe v. Wade, which is still the law of the land, although it often doesn't seem like it. But 2018 also marks the 20th anniversary of a local tragedy, the murder of Dr. Slepian, that occurred on October 23rd, 1998. Throughout the 1990s, Buffalo was a national hotbed of protests around clinics, and we have people in this room today who were both witness to those protests and in the midst of them. We are honored to have with us today Dr. Morrison, who worked with Dr. Slepian, and she will speak about his legacy later this morning. And during the break, we will be playing Annie DeFranco's song about Buffalo and Dr. Slepian called Hello Birmingham. I wish I could say that this tragic event and the misinformation and fanaticism that led to it are part of our distant history. But those of you who saw the documentary Jackson last night, which is about the last abortion clinic in the state of Mississippi, might also have read a recent related story that a bill that bans all abortions in Mississippi after 15 weeks is going to the state Senate any day. It is clear that reproductive rights are still the focus of ongoing struggles in this country. For these reasons, the timing of the symposium is critical, and I look forward to a full day of listening, learning, and conversation. Let me introduce our first speaker, Dr. Gale Burstein. Dr. Burstein is the Erie County Commissioner of Health and a clinical professor of pediatrics at University of Buffalo School of Medicine. A native of Western New York, she received her Doctor of Medicine degree from UB's School of Medicine and her master's in public health from Johns Hopkins. After completing her pediatric residency training, she began her public health career in 1993. Dr. Burstein directed the pediatric services in a large rural hospital in the eastern Transvaal of South Africa. And this was during a time that during the country's history when the HIV/AIDS epidemic exploded. In 1999, Dr. Burstein's public health career continued at the Centers for Disease Control and Prevention in Atlanta, where she conducted research and wrote policy on adolescent sexual health care. She returned to Buffalo in 2005, and in 2012, she was appointed the Erie County Commissioner of Health. Her current focus is on developing strategies to change healthcare providers' narcotics prescribing practices and to prevent opioid addiction in Erie County. She's an active member of New York State's Ending the AIDS Epidemic Task Force, and she trains healthcare providers across the country to routinize adolescent sexual healthcare services in primary care. She is also committed to making family planning services available and affordable for all. Please welcome Dr. Burstein to the Gender Institute.
Thank you. We know that this is kind of a broad overview, and we also know that there are areas of our community that really struggle with poverty, have unhealthy housing issues, poor access to healthy foods, the food deserts. Problems with transportation and education. And so those disparities are really the drivers, what we call the social determinants of health, that really are more predictive of healthcare outcomes than, say, having a clinic available. So just looking at the poverty status in Erie County, we really struggle with poverty as a big problem in our community. So 22% of children and youth under the age of 18 in our county live below the poverty level. 16% of females in Erie County live below the poverty level. 35% of African Americans live below the poverty level, and 37% of Hispanics live below the poverty level. So, again, there's a huge disparity there. Because remember, 80% of our population is white. So this is a map of Erie County looking at the distribution of Medicaid recipients. So, I want you to take a good look at that, where it's lighting up in red is where the highest number of Medicaid recipients are. You're going to see those areas, light up with other challenges, other health disparities. So first, let me talk about sexually transmitted infections. So these are looking at our reported gonorrhea cases by year in Buffalo in blue, and then in all of Erie County in red. So again, the big take home is that we're seeing an increased number of gonorrhea cases, despite our prevention efforts. And you can also see that most of the gonorrhea cases that are reported are diagnosed in the city of Buffalo. So again, it's a huge disparity there. Only about 28% of our county's population lives in Buffalo, but they're responsible for about 2/3. The city of Buffalo is responsible for about 2/3 of all our gonorrhea cases. So this is looking at reported chlamydia cases by year in Buffalo in blue and Erie County in red. And so the numbers are a bit more stable. We're not seeing the rise like we did with gonorrhea. However, we're seeing a similar pattern that many of the majority of the cases in Erie County are diagnosed among people who reside in the city of Buffalo. So this is looking at reported chlamydia cases on the left and gonorrhea cases on the right by gender. So, again, there's big disparities there where we have more chlamydia cases reported among females. Gonorrhea, it's about 50-50. And so, so again, you have to be cautious. This is surveillance data. So we only receive the number of positive tests. We don't know how many people were tested and the number of negative tests. And so we know that there are many published healthcare guidelines that strongly recommend women under the age of 25 that are sexually active to have an annual chlamydia and gonorrhea test. And so many women are getting that chlamydia test as part of their preventive health care with their GYNs. And men aren't, there aren't as strong recommendations for males, and so they're not routinely getting chlamydia testing. For gonorrhea among males, it's more likely to be symptomatic. So if a male has gonorrhea, he's more likely to seek care and get tested. For females, the same is not true with gonorrhea. Most females are asymptomatic with gonorrhea. And again, there's a disparity in health outcomes, whereas in asymptomatic chlamydia or gonorrhea infection in females still results in a great deal of inflammation in the pelvis and the infection. So the infection can ascend from the cervix, into the uterus and go out into the pelvis. We call that pelvic inflammatory disease. And then when all that inflammation and pus kind of chills off, they can be left with scarring, especially in the fallopian tubes, that increases the risk of ectopic pregnancies and actually infertility. Chlamydia is the #1 cause of preventable infertility, and also with chronic pelvic pain because of all the adhesions, and also it's a big facilitator of HIV infection. So if a guy has an asymptomatic chlamydia infection, it's not a problem for him. He doesn't have symptoms, and he doesn't have he doesn't have the reproductive organs that would be affected. So this is looking at 2017 reported chlamydia cases on the left and gonorrhea cases on the right by age. And so again, you can see there's a huge disparity there, where about 85% of all the chlamydia infections and about 75% of all the gonorrhea infections occur among people under the age of 30. And so those, as we saw earlier with the gender numbers, many of those are women. These are women of reproductive age, and so it can affect their fertility. It can also affect pregnancy outcomes. And then again, this is looking at reported chlamydia cases on the left and gonorrhea cases on the right by race. And again, you can see there's a huge disparity there, where remember that African Americans make up about 15% of our population, but 40% of the chlamydia cases and about 2/3 of gonorrhea cases are reported among African Americans. And again, that's not anything like biologically plausible. It's, again, looking at the social determinants of health and where we see poverty, and also looking at how sexual networks work. So, I'm sure that you understand, although you probably may not have thought about it, that people like to have sex with, people that are like close to them, like who live near them or go to school near them or work near them, and also who look like them. And so that's called like a sexual or social network. And if there's disease in that sexual network, say there's like a 20% prevalence, if you have sex in that sexual network, you're have a 1 in 5 chance of getting exposed and infected, compared to like somebody who is in a sexual or social network where there's no disease. I mean, they could have orgies and come out of it without any infection because they would have zero risk of exposure. So again, it's not just what you're doing, it's who you're doing it with. And again, we just see disparities there in health. So this is looking at the top 6 zip codes for reported chlamydia and gonorrhea cases, and then you can see that those are the similar zip codes that were highlighted earlier. So looking at teen pregnancy, so these are the number of teen pregnancies from 2009 to 2015 in Buffalo in blue and Erie County in red. So again, the good news is that our numbers are decreasing, which is part of a national trend. And the bad news is that about 2/3 of all the teen pregnancies occur in Erie County occur in the city of Buffalo. So again, there's big disparities there. And again, we know that in recently this sharp decline in numbers, where the curve kind of takes a sharper curve down, is really not because there are less teens having sex, because we know that's not true. I mean, there's a small percentage decrease, but it's, it wouldn't account for these data. It's that there is more effective contraceptive methods available, especially long-acting reversible contraceptive methods, or LARCs, like implants and IUDs. You don't have to think about anything. It's on autopilot for 3 to 12 years, depending on the method you choose. So these are looking at teen pregnancy rates per 1,000 females in Erie County in red, in the city of Buffalo in blue, and then in the rest of upstate New York in green. So you can see that the city of Buffalo has much higher rates, numbers per 1,000 females compared to the rest of Erie County, and then compared to the rest of upstate New York. And then this is looking at teen pregnancy rates by race. In Buffalo on the left, and all of Erie County on the right. And again, we see another health disparity there. So looking at the top 6 zip codes, again, these zip codes appear repetitively with health disparities. And if I were to show you, map out, high rates of cardiovascular disease, high rates of cancer, the same zip codes would continually, high rates of obesity, the same rates would, the zip codes would continually light up. So, anyone want to make any comments on that, or yes, in the back?
So what is Erie County doing as far as outreach to your target market, the teenage market and beyond?
Right. So we are fortunate enough to be working collaboratively with a project called Hope Buffalo, and that's a project with the collaboration with Chickatelliot Associates, and we're really engaging the community, including youth leadership, to try to address these changes. I mean, ultimately, the biggest effect that we could see if we were able to change the social determinants of health, and eliminate poverty, and get safe housing and improve transportation and education, but those are harder lifts. So we're kind of working with the community to raise awareness. Yesterday we just had a press release looking at a referral guide where teens had a great deal of input, identifying offices that could provide teen-friendly sexual reproductive health care that was safe and confidential and comprehensive for teens. We're working with the Buffalo Public Schools to start providing education around sexual health at a very young age. Even in elementary school, there can be age-appropriate messaging, just with smart choices and how to say no and good decision making. So we're we're working with our providers to provide them with training that's actually led by youth, an interactive workshop of how to make your office more teen-friendly. And then we've, with the health department, we've been working with pediatric offices to do a quality improvement project in collaboration with the American Academy of Pediatrics, so they can get their educational and board certification credits to help them figure out how to routinely take a confidential sexual history for adolescents, and then when they identify a teen that's positive, routinely order a chlamydia test, and then also provide them with information around family planning and ideas of suggestions of where they can go if the office doesn't offer these services. So it's a big problem, and I think that the community has to own it, just like any type of stigmatized behavior or challenge or outcome. And how do you address stigma? You kind of talk about it, you show positive role models, you give resources, and so that's, I think, one of the reasons why we're here today is to work together, and also to think about some, highlight some other challenges, reproductive health justice, and then think about what we can do together as a community. Thank you.